Hey everyone, it's DrRic. Today's topic is knee pain. And I've kind of addressed this in the past with other tutorials like DrRic tutorial exercise for knee pain. I think I mentioned it in arthritis. But here I had a patient that came in and said she was given a shot in the past, was suggested to have the gel shot. The first shot was steroids and it temporarily gave a little bit of relief. The gel shots were suggested by the orthopedic surgeon, but patient decided not to go forth and was given a handout on exercises to do. And I think a handout is worth its weight. It's a handout. Yeah, I really think if you want to maximize on treatment, it's not just you read a text, but you also have to know the dynamics of how the exercise has to be performed, how you, with your imbalances, and everybody's got alignment issues, with your imbalances or alignment issues, will use the specific exercises, how you have time in your day to do these, how often you should do them, what other things you should do with a nutrition plan to take care of the inflammation while you're doing these exercises, how much sleep you have, how to change your exercise routine to incorporate a rehab program. So there's a lot of things that have to be involved. And sometimes a piece of paper will not suffice. So in the case of the average person with knee pain, it usually comes down to a couple reasons. Kneecap pain or patellofemoral syndrome, meniscus tears, ACL tears, or you can have a bone fracture or bone spurs. That's the arthritis thing. So that's typically the reasons for knee pain. It could also be knee pain referred from above, like the hip, or knee pain referred from below, like the ankle, that just shoots into the area and it's mistakenly thought of as being knee pain. But for the number one reason, which is patellar irritation or patellofemoral syndrome, this is a right knee, kneecap, the femur, the muscles that take care of controlling the kneecap, the little menisci or pieces of cartilage that help the knuckles of the femur sit on the tibia, that's the shin bone, and then the tibia and its fibular head right here. So this is essentially what you see, what represents a knee. This is the knee from the side. Again, femur, kneecap, tibia, and the muscles around it. So this thing should work till 80. It'll get a little bit arthritic, both on looking at a knee on the outside and seeing x-rays. So those of you who are 50 or 60 and above and doctors got an x-ray and said you have arthritis, that doesn't necessarily mean it's the reason for your pain. That could be incidental. I mean, if you're older and you have arthritis, big deal. If we x-rayed everybody's knees from 60 years on up, I guarantee you 75% would have arthritic knees. The question is whether those things you see on x-ray are causing the things that the patient is suffering from, and that's not always the case. So if it is a kneecap issue that's rubbing excessively, and this one I guess you can think is loose, if it's rubbing excessively, no knee will tolerate that forever. So what we want to do is have the thing rub in the right direction, and I'll show you what it's supposed to do. This is, come up closer, this is a kneecap. And the kneecap sits on top of the femur, like I mentioned. Oops, this one's a little broken. And this is a right knee as well. A little fibula on the outside, the tibia here, and this is the femur. Femur's knuckles, which are smooth here, these are supposed to be lined with cartilage. They sit on top of the menisci. Menisci are C-shaped pieces of cartilage. This is an ACL that's torn. But it's supposed to sit like this, and you can see that there's a groove right here. Well, on that groove sits the bevel of the kneecap. And so you can see the kneecap, if it's pointed enough, will hopefully sit on this groove forever. In women, the kneecap is a little bit, it's kind of shallow or doesn't point as deeply, so it has a tendency to move to the sides. So in women, the tendency is because the groove isn't as deep and the point isn't as pointy as a man's, you'll have a tendency for it to go to the sides, especially in certain positions, like standing straight up and down. Now, when you hyperextend like this, like in something called sway back knees as you're a gymnast, you'll actually be able to float this thing more. And sometimes as you come down and hit a plant, like in gymnastics, you ask the kneecap to go pow. And when it goes like that, as you come to attention, it will irritate the surface, which here is roughened and grooved. Not supposed to be like that. It's supposed to have a lining of cartilage here, a lining of cartilage here, and it's supposed to go with a drop of fluid for 80 years without any problems. Obviously, as this thing goes straight, extend, flex, this will irritate. And when it irritates, it'll, again, if there's not enough cartilage on the sides, or not enough fluid here, or there's excessive amounts of irritation, it'll grind it down. So the problem is when you grind it down enough, you cause friction. When you have friction inside this knee, it'll cause the knee, the synovium, there's a wrapper here that keeps the fluid in. The synovium will sense that there's irritation, and it'll send more fluid. That's that puffy knee that some people get. Eventually, the knee will, the synovium will absorb it again once the inflammation decreases. That's usually because of our keeping it still, or putting a wrap around it, or walking like with a limp. When you do that, you decrease the inflammation. When the synovium senses it doesn't have any more inflammation, it sucks the fluid back in. In the rare case, if you have a lot of irritation to this thing and the synovium starts to accumulate fluid, it'll actually pop a hole to the back, collect a little bubble of fluid here called a Baker's cyst. Baker's cysts are painful because once they pop a hole through the back, even if the front fluid goes down, it doesn't necessarily go back in, and you wind up with this little marble in the back of your knee, and there's no space back there. There's nerves and blood vessels, and they get pinched off because this mass is back there. So again, the idea is to decrease the swelling, but that's a temporary response, and we can pull fluid out, pull blood out with a big needle, or we decrease the reason for the fluid to accumulate, which is either traumatic overactivity or just excessive amounts of friction. So there have been some cases where I send people to physical therapists and they'll do mecanal taping where they'll, especially women, they'll tape the kneecap to, I guess, give a sense that you're supposed to walk this certain way, and no tape will actually hold this thing and prevent the kneecap from subluxing or moving in and out too aggressively. But sometimes when you have tape constantly pushing, it gives you a sense, walk properly, it gives you just feedback. That's all the sleeves, the taping, kinesio taping, that's all it really does, is it gives you constant feedback to your skin and muscle to tell you to extend at attention, keep your posture, or walk in a certain position, don't cut too much, don't rotate too much, because you have constant tugging of that tape. I mean, anybody, even if you had a cast on, you can break through the cast. If you had tape on, it gives you a little reminder to stop, but you know, you can always break through the tape, you can pull it off. So that's the idea of taping with a knee until you have developed a sense of movement, a muscle sense, muscle enlargement to control this knee. That's the other thing to talk about is when you have exercises and say you have arthritis that's coming or already here. What happens with arthritis? It's a response that the knees or any joint gets because of excessive amounts of force being applied to the joint. In the case of arthritis, knees always get the brunt of the force or friction of the body, especially in walkers, truck drivers who have to use the pedal all the time, construction workers who have to hammer with the arms. So those joints always get worn down. Even anybody that's typing a lot or writing, you'll have a lot of problem with the wrists. So any joint can have it, but in some cases when you overuse a joint more than the average human being, those particular joints will get the friction will be interpreted as extra force, so the joint will throw in either more fluid or more calcium to the area to take the brunt of trauma. That's the arthritic change. Unless it's an inherited disorder like rheumatoid arthritis or gout, those things will cause the body to overact in an abnormal way, even at a young age, to no trauma. It just forms calcium deposits and ugly looking bone. So when this kneecap, which is the #1 reason for knee pain in an office, kneecap is not functioning, say it's pulling off to the side a lot, or the angle of the foot is off, so it's sending or throwing off this Q angle or the angle of the kneecap, riding up and down, you can actually change the size of the muscle. This one here, there's 4 muscles, the quad, that's why it's called quad. This quadriceps muscle here, this quad can be changed. If you ever look at the thighs of a cyclist, either road cyclist or a cyclodrome, he'll have huge, usually big quads to begin with, but really huge vastus lateralis muscles. That sometimes opens those guys up to iliotibial band syndrome, and see my video, DrRic question iliotibial band, ITB. But it opens them up because they're off balance. But there's a guy named Tom Platts that I used to follow when I was bodybuilding, Platts. He was huge. If you ever want to see good quads and muscles, I don't know if they were good. They were probably out of proportion, but they can see well-defined muscle layers. Vastus lateralis has to be big, but vastus medialis, the one on the inside that pulls the kneecap this way, that also has to be big. So think of it this way. When you have a stagecoach and you have reins on the horses, you have 4 horses or 6 horses, you'll have a rein on each of the horses. And if you pull more on this side, then where does the stagecoach go? It goes just to the right. And if you pull more on these reins, your stagecoach will go to the left. You want the stagecoach right in the middle of where you want. So if you're pulling excessively to one side, your kneecap's going to want to go that way, and it's going to grind more over the course of years. It's going to grind more on the outside, or it's going to grind more on the inside, depending on how this VMO over here is developed. So you want this neutral. You don't want it coming to the side. You don't want it coming to the inside too much. Usually it doesn't come to the inside like that. Usually it's getting pulled this way. Especially with IT band or iliotibial band syndrome along the side here. If you have a lot of irritation to Gertie's tubercle and the fluid here, the bursa, it's going to irritate, it's going to pull that way, and it has a tendency to throw off alignment. Same thing with the foot. If you have problems with the hip or the foot or the ankle, it'll affect the way the kneecap is riding, opening yourself up to friction. So the Tai Chi or my acupuncture dummy shows a nice alignment, nice Q angle, but not everybody. If you go to a pool in the summertime, you watch everybody's feet, most kids are flat-footed, their angle is off, and that opens them up to a problem. You don't necessarily have to get orthotics. I have a great, Dr. Bob Weil is an orthotic specialist, a podiatrist that I use. He even puts them into skates for Olympic skaters, but you don't necessarily have to put an orthotic into every foot, every shoe, but when you have an alignment issue, definitely with a knee pain, they're worth treating. Sometimes physical therapists can do low-dye taping to kind of pull up and tape and see if fixing the arch temporarily for a couple hours would alleviate the knee pain. Sometimes you can get those Spenco orthotic insertions. They're temporary ones that fit the general public just to ramp up the foot to see if it changes the pain in the knee. So those are always options, but seeing a podiatrist would be the best thing for you. So exercises, getting back to exercise, you really got to do something different with regards to the development and strength of these muscles. The problem is, while you're doing those exercises, if you don't exercise, what's it going to do? It's going to hurt the knee. So you have to know exactly what to do. And in addition, flexibility should be done too, because if these muscles back here, called the hamstrings, are way too tight, it's going to make it even harder to work on the front muscles called the quadriceps. If the calf muscle is too tight, if the Achilles is too tight, if the plantar fascia is too tight, it's going to affect the way the kneecap rubs. So with this #1 diagnosis of kneecap pain, patellofemoral syndrome, you really have to work on flexibility. Then you have to develop a specific program. Even if there's arthritis, the only thing that postpones a knee being replaced is muscles that control the joint. If there is a wear and tear that's already been initiated to the knee, then you're stuck. Probably can't reverse that, but you can reverse the strength of these muscles, the flexibility of these muscles, even if you've never done that before. One of the worst things that I can see in the gym is when doing exercises for the knee, you figure, oh, I just developed my quads. But there have been countless studies in the past that show this kind of exercise. This is called an open chain leg extension exercise. This, you think, will develop the knee. I used to use a Cybex machine way back in the 80s because we thought that really worked on the quad, and it does. But it causes force to go this way, right through the kneecap, versus a leg press machine where you're planted, the force goes into the stationary object, like squats, leg presses, slides. So the objective is always to put your foot on a stable position. Not that cushion where you're doing the leg extensions, but foot on a stable position. That way you can develop the quad. And my bodybuilders know that they like the leg extension exercise because you can really get a blast to your quads. But all the studies have shown that if you do closed chain exercises, they will get just as much strength as a quad extension exercise. You won't get probably the size that you're looking for if you're a bodybuilder, but we're talking about strengthening up the joint, strengthening up the quads without causing any further damage, and making this thing very stable so you can tolerate the activities of what you're supposed to be doing for the rest of your life without having to go to a surgery. Now, if you have to have a partial surgery, okay, steel will get you a new knee with less friction, but even if you replace this bony prominence with steel, you still have to use these muscles to control the steel insert. So it still goes down to doing the exercises again. And as far as I know, they have not replaced the kneecap yet. It's usually the bone, this kneecap is buried. This thing is buried in the patellar tendon in the quad. This is attached to the quad, the four muscles here. So it's hard to replace this bone. It's easy to replace this, even the tibia. You can replace the tibia. They are working on meniscus grafting, but only the high-tech places, teaching universities can really get that. I think Japan, they're working on meniscus grafting. But ACLs, you definitely can replace the ACL. That's the other thing. The two other big causes would be meniscus tears, and that's these two things here. If you have a tear to the meniscus, as of yet, they don't really have a replacement, but you can kind of chew it down, you can kind of shave it down, you can tack it down with staples or suture it. Sometimes you can inject, but it's tough to, I haven't seen great reproducible evidence that says that you can get a really good meniscus. ACLs, you can take a hamstring, triple twine it, and then put it in instead. Pretty decent results, whether you use hamstring or patellar tendon. I think that's fine. You can have basketball players slam dunking in 4 months if you wanted to with a new ACL replacement, even if it's a cadaver. But those are more surgical. For that, you will need to rehab, and you'll be under the strict protocol of the surgeon for the rehab. Menisci, when they cut them out or cut off the rough parts, usually you hobble into the hospital and you walk out because the rough part is taken care of. If it's a meniscus replacement or if they tack it down, you can't walk for a couple weeks to a couple months, I believe. If it's a Baker cyst that they're cutting out that's painful, you cut it out, it's done. But again, you have to figure out what the source is. And during all this time, you still have to work on your weight. If you're obese and you're getting your knee, you're trying to work on knee building, losing the weight will take the force off. If you have a foot problem, as I mentioned before, a hip problem, that's got to be taken care of. If you have an inflammation issue, like you're eating a lot of crappy food on the wrong diet, change the diet first. If you're on your way to surgery, change the diet before you get into surgery to fix anything, because after you fix stuff, if you still are on a bad diet, smoking, too much alcohol, not enough omega-3, no turmeric in your protein or in your food sources, you're asking for trouble. Omega-3 is very good, turmeric is very good, glucosamine sulfate, excellent in European studies. They used to use that back in the 90s. And it's still being used now, but there are side effects to turmeric, glucosamine sulfate. Even SAMe works great for knee pain. We're not sure exactly what it does, but people have better range of motion after getting on SAMe. So those are all the things that encompass what you're supposed to be doing when you have knee pain. If you can't do it on your own and don't have anybody around you to watch your movement during the exercises that were given to you, ask for a visit to a physical therapist. Physical therapists can watch you in the water, watch you on a treadmill, watch you as you perform your exercises and see whether you've done enough. Look at your ankles, look at your hips, look at your alignment. Chiropractors also can do the same thing. So all these folks can be your coaches for figuring out if you're doing the right thing with your own rehab. I know physical therapy is expensive, chiropractic is expensive, all these folks are expensive. But if you look at it, so is time off if you have to have a knee replaced, or disability, and you'll be off for a long time. If you can't get the knee replaced, then it's just caused so much chronic pain that you'll be seeing the chronic pain docs or getting medical marijuana. So it does sound like it's fun to get medical marijuana, but not if you're truly suffering all day and you can't walk. The only thing not walking does is it makes you more apt to have obesity, pneumonias, depression, because you're not mobile. You got to have mobility. Also have to be pain-free somewhat. So.